our guest panelists. Thank you for being here, Flavio. Good to see you again.
Thank you for the invitation.
And I want to kind of get started by asking you, a quick perspective on, what is your general process when you are starting a journey with a new patient that just presents themselves to you?
Yeah, well, first of all, thank you so much for this opportunity. And I consider so crucial when we are seeing patients is, first of all, having and establish a very good rapport with them to see if we have the possibility to work together. Obviously, collecting all the necessary information from the point of view of the clinical aspect, but paying attention to what are the patient's needs and expectations and desires. I think that is so important for us to spend enough time listening to our patients before we can initiate any type of complex treatment. And I experienced through the years, the more that I listen to patients, I have the ability to identify when you have to decide if you can treat or not the patient.
Yeah, so there's a lot of upfront thought process conversations before we actually get into treatments. So to really kind of help us understand this important part of our treatments, which we seldom talk about, we always focusing on procedures, how we do things and steps. Today, we have a very interesting case that we want to present and this is a patient that we both treated together. And we're going to share that with you and, really share the complexities and the difficulties that we face along the way. Hopefully, it'll be of great value for everyone. So let's go ahead to our presentation. All right. And so let's start with the patient history. I'm going to have Flavio give us a background on this patient that presented to him first.
Yeah, so the patient present to the office just for a dental cleaning. The only issue is that the patient didn't have a clear understanding of the condition that he was presented with. Last time that he has seen his dentist was close to a year and a half, 2 years ago, and he was expecting to come to have an evaluation to go through a regular maintenance appointment. And then obviously the surprise is that he didn't have just the condition that we can just provide a service of maintenance without addressing other things. And when this patient came and he started spending time with him that particular session, I realized that he has suffered depression for almost 20 years. And he has also suffered due to the condition that he presented with. Unfortunately, he was out of a job. So he was, even though being a highly educated individual, was not able to every day go to work. And that has created even more problems being disabled for close to 20 years. And had only, his spouse that was the one that was receiving a salary. Now, clinically, obviously, he presents with existing conditions that are multiple caries due to the fact that the patient had, this medical condition that is related with depression and bipolar disease. A few of the medication that he was taking was inducing xerostomia. So those are things that obviously, when you start seeing that the patient present to our office with these characteristics, the first thing that we have to consider is this the right patient for us to initiate any type of therapy, unless you spend enough time to identify if this is the right patient for you to be treating, and if the patient's expectations are clarified. So obviously, we took in that session all the necessary images to confirm the status of his dentition. And then I had a preliminary discussion with him, understanding that he will have different type of treatment options, but only one diagnosis. And the treatment option that we discussed, it was having the options of preserving his dentition, preserving the existing teeth, understanding the risk factor that he has, Moving toward dental implants, which is definitely the option that I consider on this situation, maybe the best option that we can offer to these patients, either just considering an all-on-4 or as many implants that we consider necessary, or if we preserve the existing ridge, then moving toward implant support prosthesis just as a crown and bridge type of design. Obviously, the option of a removable type of prosthesis, kind of an overdenture, is considered perhaps in patients with this type of condition a valuable option for them to discuss with us. And the conventional prosthesis with, if we elect to go in this route, that sometimes due to financial reasons we offer this to the patients, we have to be aware what are the major limitations with conventional or traditional prosthodontics. So the treatment plan consideration in this type of situations are very important for us to discuss. So again, we are dealing with a patient that has multiple caries lesions, has a very strong, bone structure that we can utilize dental implants. But one of the components that are playing a major role in here is the financial condition that this patient present with. Because when I start going over the different possibilities, this patient was unable to afford what was perhaps the ideal treatment, which would be in this case, preserving the bone structure and then convert this patient in implant support prosthesis, perhaps just multiple implants, breaking this in segments. That's without a doubt, based on this patient's condition, would be the best choice. Mm-hmm. So the diagnosis, just to review this again, are non-restorable teeth due to large pre-existing restorations, multiple composite that were deep subgingivally. There is enough bone structure that we can definitely consider for a fixed type of prosthesis. And obviously, that, as I said before, the best option that we can consider in this patient will be that. There are certain factors regarding the challenges that we are facing. This particularly, the challenge is related with the existing oral health and the mental status of this patient. It means a chronic condition of depression that the patient was dealing with. And there are certain physical limitations as far as the oral hygiene that the patient present with, and the financial constraint. And when we were talking with them as we went through the process of presentation of the treatment, I found a significant limitation in the ability to connect with this patient. And those are the moments that you start making the decision, okay, the risk factor that this patient has are very high. There is definitely certain demand from the patient, because as I was talking with them and his wife, they would like to have the best treatment option, but financially, unfortunately, couldn't afford it. And then the expectation not only were related with what we can do for them, but then through the course of the treatment, we face multiple time challenges just to maintain a very good relationship through the process. Now, there is obviously, when we present this complex treatment plan to the patients, we're trying to break this in certain categories that I learned this through some of the prosthodontists that we have as educator, this Dr. Coyce, that he very wisely described this as you have patient categories of risk assessment: biologically, biomechanical, functional, phonetics, and aesthetics. And if this patient has to be converted in an implant support prosthesis, we have to make sure that we can identify where we're going to be facing complications. So this treatment sequence, when we start planning for the treatment on this patient, we discussed the option of going through the extraction of his teeth due to the fact that financially, as well as his mental illness, wouldn't allow him to try to go through the process of preserving his teeth. It would be too much of a risk for us to embark in that particular approach. I trust implants. I work with implants daily, and situations like this, I consider that are the best choice. The issue is the cost that it is obviously involved in this. And regarding the treatment option that we present, I send the patient to you where you have the possibility to meet the patient.
Right.
And we consider the option of having an implant support, eventually prosthesis. Going back to this, as you can see in here, we can very well have these extractions completed, have a fixed type of prosthesis implant supported to be considered. But since we had limitation financially, we elect to go through immediate upper and complete denture, planning for an overdenture design in case that this patient wouldn't be able to get acquainted to a removal conventional prosthesis, which is what we have done in him.
Yeah, I think it's interesting. And this is a crossroads that we come often quite where we have a patient where we have an ideal treatment plan. Certainly in him, some of the teeth perhaps to be restored, a number of them to be extracted, site preservation, implant therapy with fixed prostheses to mimic what nature had intended. These are all possibilities, especially in a patient like him that has good bone and soft tissue support. But then the conflict comes into that we cannot do what we think is the right thing to do, whether it's because of patient's financial limitation or because of their health for various reasons. And that becomes kind of a very difficult conversation in terms of offering an alternative that is certainly not the way that we would like to do this as clinicians. And I think he was a good example of that, knowing that we would have to go to a more reductive, more aggressive type of a therapy to meet his needs, and not only financial, but also what he was looking for. So I think this is a very difficult task that every one of our clinicians, everybody that I know has come across. And so we have to work through it. I feel like we have to sort of think it through, and this is a time to slow down and have more conversations.
Well, one of the things that I faced with him was normally I collect the data. I have that first meeting where it was a question regarding how much we can do for him in that appointment, and then require a comprehensive care that he was not expecting to have. That. Then through a series of sessions that we come up with the definitive plan, I start getting multiple impressions. We were getting multiple patients' emails regarding some of the issues as far as his expectation, what he was expecting from us. And that's where you start determining, is this the right patient for you to treat? So we asked, we went through all this training, and sometimes you feel that you can help every single one. And that's one of the things that sometimes we made a mistake. And I recall my partner was looking at me when I went through the treatment with this patient. And he says, "Why are you doing this?" I think that you're going beyond what sometimes you can really do for the patient. Still, in a few situations, I have faced certain interaction between the patient and my staff members, where you can realize that there is a mental illness that this patient was suffering that can really affect the interaction with the entire team and with us as a provider. One of the important factors in here is establishing a good relationship with the existing clinicians that are taking care of this patient. I think that in patients that are suffering from a mental illness, it's very important to find out, especially on him, that he has a psychiatrist that was taking care of him for 20 years. So the connection with this other colleague has been very crucial, because that put me in a situation that I understood that I'm going to need to be much more patient with this patient, understanding that this at the end ended up working well for everybody, but it was not an easy journey.
Well, I think what's interesting is, certainly certain patients that we see clear sign of mental challenges or health, but we also come across patients who are not necessarily categorized by history of mental illness, but they have deeper emotional experiences in their lives that maybe we need to open our eyes to, whether it's subclinical depression, whether it's other events in someone's life that affects their well-being during that time. I I think it can affect the decisions, it can affect the judgments, it can affect the healing process. Certainly, we talked about this a lot before about how the emotional and the energy of the patient can influence how they actually do the therapies. So this is certainly, I think, the other challenges, and always say that, when we were younger at our early part of our career, it seemed like we could do everything and nothing was a challenge. And sitting here, 25 years later, I feel like I have um, a lot more filters to work through the cases. I'm a lot more humbled. I'm a lot more
Absolutely.
cautious. I'm a lot more, I ask like 100 more questions than I used to. And I think maybe that's just part of experience. And you can't, that just comes with life as we know it.
And I know that the more that we do this, the more that you learn about your mistakes. But still, as I said before, we went through such an extreme amount of time and dedication to train ourselves, and we think that we can help people because we have the skills. But sometimes there are so many other factors we have to consider before you get involved into it.
Yeah.
So from the point of view of the procedure itself, obviously, once the patient accepts the fact that he's going to have a first phase of the treatment, which would be eradicating disease, and that's where we proceed with certain selection on decision and where we had to determine if we had to fabricate a prosthesis on him, determine where is the midline, where is the smile line, if we are planning to consider if dental implants are going to be part of the treatment, where the implants could be placed. If we are planning to have an overdenture, we have to understand there are the dimensions. If we are planning to have, obviously, an all-on-4, what is the amount of occlusal clearance that is necessary? And we sometimes have to be a little more aggressive based on what is the type of prosthesis design that you are trying to have. So on him, we fabricate upper and lower complete denture, where we use as a reference some of the existing parameters and reference that he was giving me because I was able to see the two structure that he has. So the day of the surgery, obviously, we have to have a decision made ahead of time where we're going to have, if there is any need for alveoloplasty. And in this case, I'm sure that most of the audience will be wondering, why did we have to remove this much bone? And so that's where the discussion was coming, we had before, is depending upon where you want to go from the restorative point of view, in this case, prosthetic point of view, you make decision about where you have to select the interface where the prosthesis has to be.
Yeah. And I think this is a critical conversation that, before we get to this point of alveoplasty and bone reduction, as you see in this slide, let's go back to this slide there. And this is a pivotal point of a conversation with the patient about alternatives, because once we do this, there's really no going back. And I think, given this case, again, the ideal approach would have been to preserve the bone, the alveolar ridge, place our implants, and if anything, make additional bone grafting to augment, be an additive clinician, not a reductive clinician. But certainly with the limitations and decision under the prosthetic design that he agreed to and was feasible for him, we have to perform the alveoplasty. So at the time of the extraction, this was done, just really reduction of about 3 to 5 millimeters conservatively, since there'll be some remodeling, of course, after the extraction. And then we simply just let the site close. This is about 6 weeks later when, he was given the immediate denture with a reline and then another reline at 6 weeks.
Yeah, usually what happens on patients that are, number one, patients that suffer xerostomia to some degree, and getting adapted to a complete upper and lower denture is not a simple process. So that's where important aspect of this conversation at the beginning, understanding what the patient may be going to be dealing with. The beauty is that we have always the possibility to consider dental implants. So at this point, after around 4 to 6 weeks, I realized that the patient was having difficulties. adapting to the conventional upper and lower prosthesis. That's where we start discussing what would be the next case, the next phase, or the next step. So looking at the bony structure that we have, now the disease has been eliminated, all of the teeth that were compromised has been removed. The patient has had multiple teeth on the anterior segment with periapical pathosis. So we have now the possibility to plan for dental implants. And we went through the same discussion with the patient. Well, financially, I have significant limitation. There are certain things that I cannot do. And at this point, I believe that we have two paths of treatment. Either you stick to the patient and you take care of them, or you start, planning to say, well, this is as much as I can do based on your possibilities. And I don't know about you, but I feel that, we have the chance to help people. So we found a way for him to set up a payment plan so I can have this patient going through the process. So we incorporate temporary implants to help him with the retention of the lower overdenture in this case. And at 1 week after, sutures were removed, and these temporary implants are from 3M, if I'm not mistaken. I
That's
think that's the one
correct.
that you
Yeah,
have.
there's our temporary implants that just provide the support for transitional prostheses. Obviously, it was used for the lower arch because the main problem with the transitional overdentures not having the advantage of the palate and the upper is patients have really difficult time keeping these prostheses in. The tongue, the muscles, and the vestibule to a large degree reduced. So this can be a good transitional strategy for patients.
Yeah, and I usually tell patients that when we go through the conventional prosthodontic treatment of upper and lower complete dentures, they are going to eventually request implants unless they have that unique ability to function with something that is with some degree of mobility, And lower prosthesis with the presence of these 4 temporary implant has improved the lower prosthesis significantly. The retention has been to the point that he was able, start feeling that we are making progress. Now, the issue is once you have a lower arch that is more stable, then the opposing arch become as the next challenge. So, and the patient will come and says, doctor, I see the value of having lower implants. I consider perhaps that it's necessary for me to discuss what are my possibilities for the maxillary arch. So that's where I recall that I have this conversation, and I will be getting and receiving the email from him, long emails describing the experience that he has just noticed of the improvement of his function.
Yeah.
And one after another. So that is telling you that we have to move toward dental implants. So this image is showing you the presence of the lower temporary implants and just insertion of a soft tissue reline, and around the temporary implants, I just use a silicone-based reline material. But they come with, these are housing that you have to obviously pick up with acrylic, and you have to block out underneath to avoid that the acrylic is going to be stuck, get stuck into the surface of the temporary implants. Once we have this functional, then we start considering the upper arch. And then we have the discussion with the patient. The minimum amount for an upper prosthesis would be having 4 implants. Well, when we discussed financially, there was another major challenge because it was a difficult possibility for them to just put all their investment to our dental care, understanding that they have other needs. So it's kind of I really appreciate at that time when we had this conversation that we both felt the same way, is helping this patient through the process will definitely make a difference on him. And that's why you start making a decision is how much you can put toward the care of a patient, giving up adjustment of your fee schedule and the
Right.
time that this requires.
Well, I think that's kind of yeah. I remember the conversations quite well. I think at that point we both felt that we were really committed to him, and we wanted to see him through in a better place. And there was really no other option. I think either you decide to stick in the game and go all the way, or recognize at the beginning that this may not be a fit for you. But then I think it's okay to have that. It's okay to say no to a patient before you get started if their needs cannot be met by what we can provide. But at this point, we're in the game. We're already have a relationship. He already has the trust, and we said, yeah, we will take care of you one way or another.
Yeah, and the other thing that happens at this stage is, you know, how things evolve from the technological point of view in implants. So when we start planning this case, we knew that it would be important to have 4 dental implants. So we start considering the option of an implant support over denture because his dexterity was not great. And we planned for 4 implants to have the distribution so we can have a way out in case that an overdenture design wouldn't be feasible for him. Why? Patient that has dry mouth, severe serostomia, there wouldn't be much of a change regarding that part. Right. Certain patient with an overdenture, some of them will have limitation in the ability for the prosthesis to function when there is, you know, such a limitation in the amount of saliva. So we have these 4 implants, which we decide to use Straumann, and this.
And just a comment about how we sort of set this up here. So we actually had the denture set up, and that was a reference. And the process of the digital workup, we used a dual scan process, as it's known. So we put these markers, as you can see on the monitor, the white little balls that are placed in the denture. We scan that into the patient's mouth and also separately. And with the software, we merge the 2 data, and that's how we can come up with the position of the teeth from a digital standpoint. And all we're trying to do is line up the 4 implants to give us as much AP spread as much as possible. With the fact that he had some this posterior aspect with some sinus pneumatization, that we would tilt those implants in the back to get some additional posterior coverage as best as possible. So that's how we came up with this.
And then at that time, which was close to 4 years ago, more or less, I was exposed to the option of a Kona System from Astra. So I thought that would be a good combination, having the distribution of the implant that can give me a biomechanical, a favorable AP spread, regardless if I'm electing to use a fixed type of prosthesis or removable prosthesis. So I think that would be wise for you to see the surgical intervention.
Okay.
That would be very.
So that was the design that we used. The Kona is considered a fixed removable option, where it feels like a fixed prosthesis with friction fit, but it's removable. Yeah. And that's really kind of the design of this approach.
And the interesting part is because I recall going to one of the ACP meetings, and I saw one of the presentation, and the clinician I was presenting was, you know, it seems to be very simple process. The issue is then you have to have the laboratory support to make sure that they perform all the necessary steps for this friction fitted system that you can have a very stable you know, prosthesis.
And we'll show you what that looks like. Yeah, but it's not as simple.
It's not that simple. At least when you attend a lecture, usually you come out of there and you feel that there's something that you can apply, but you have to be careful sometimes.
So let's take a look. Once we completed this, from that we fabricated a surgical guide. So this was meant to be a bone-borne, actually a tissue-borne surgical guide, fixated with some pins for reference. And we followed the guided approach for the site preparation, 4 implants, The precise angle and the trajectory of the implants were defined in the surgical guides because the accuracy of the parallelism and those tilted implants is crucial to be able to accomplish a path of draw for this. So here's the position of the implants and just closure, allowing these implants to integrate for about 3 months. Here's a radiograph postoperatively.
One thing that I always see the surgical procedure is completed, then prosthodontically we start dealing with the healing process with a removal prosthesis, unless you have the possibility to do, and in this case, a fixed provisional prosthesis that it is delivered at the time of the implant placement. Now, due to the financial restriction of this patient, that's where we have to maintain the existing complete upper denture just with a soft liner, so we can help this patient go through the healing process until these implants are ready to move into the final prosthesis.
Of course, these implants were quite stable, and if we were planning on a fixed hybrid design technique, we could have easily done an immediate load protocol with 4 implants of great stability. The patient can get a fixed transitional prosthesis supported by the 4 implants, and really is a remarkable transition rather than going to a full denture.
Which we use this all the time.
Yeah.
But thinking on this particular situation, we're trying to avoid having the patient going through an extra expense. But this is part of the entire process.
And that was part of the limitation. Exactly.
So at this point, we are moving to our now upper implants that are healing. I think that is 1 month after the surgery. And we have maintained the vertical dimension. So from that point of view, he's satisfied. The lower prosthesis was stable. And we reach a point where now, since the type of prosthesis that we want to fabricate is going to be maxillary overdenture, and after you have confirmed the full integration of the implants after 3 months, now I obviously use the existing prosthesis as a great reference for me to determine what are the things that we had to change. So one of the things that when I talked to the patient, he was requesting to have teeth that were slightly bigger with a different shape, a little more oval, instead to have more triangular shape. So a few things that we discussed at this point with the patient, and he started getting excited about the next phase of the treatment, as well as I was getting excited, because I would have the possibility to start incorporating a new type of prosthesis design that could most probably help many other patients. So we go through the process of final impression. In this case, the maxillary arch, we made an impression to the head of the implant, planning to then have the custom abutments created for the Kona system. And then the lower arch, I just made a final impression after border molding, planning to use a mandibular support overdenture. At this point, we go through the conventional steps of having jaw records, occlusal rims, verification of the vertical dimension. Having an existing prosthesis give us a lot of information to determine if we have to have any further changes in the vertical dimension regarding the aesthetics. We can see if the midline, in this case, if it was an immediate denture, you can see that it was slightly more toward the right side. So that has to be modified. We test phonetics. And one of the things that I have also as a challenge with this patient is that he has had early on in life a speech impediment. So when we move from having fixed type of natural dentition into removable, many appointments we went through the back and forth of where the teeth has to be. Imagine when you have an immediate complete denture that you don't have the ideal stability and retention. So, and this all will obviously build up over time the degree of exhaustion that you reach at a certain point of dedicating so much effort on this type of care. But anyway, at this point, we are moving toward the next step of on the next appointment having what is called a jig that I have to connect to the head of the implant to make sure that then a master cast is accurate. And since I have teeth, I can always get a reference of the teeth of the existing denture. So this is kind of giving me some sort of information if necessary when the patient is not with me. Now, one thing that happens with this patient due to the xerostomia, the depression, time to time, you will see the patient that was unkept. So coming to the office where he was not, unfortunately, very clean. And there was multiple times where he developed, you know, a fungal infection. And we have to obviously put the patient through an antifungal therapy for a couple of weeks until we can see that the tissues start getting stable again. So at this point, I have the maxillary and mandibular prosthesis to be delivered. And we were both excited, the patient, myself, and my staff. So we go through the process. One thing that is very interesting in this system is that from the laboratory, as long as you have provide a verification jig, means that you have verified that the master cast is accurate, then the laboratory fabricate these meal abutments that can be made out of titanium, and or they send you the case with a jig that facilitate the delivery of these abutments. And this picture that you're seeing here is to show you the importance of having a parallelism, because there has to be a path of draw so you can have that friction between the metal component that goes into the abutment. What you see on the left side of the screen, there are four metal components in there. Those are the four housing that are on the pieces that will go into the Kona system, and then the other four that are red color base, those are the ones that will be into the lower overdenture. That is just an O-ring, you know, basic system that will be retained by the temporary implants. We have to place these washers in there so we can minimize the chance for the acrylic to go underneath. And the other thing that in the Kona system, it's important, the angulation of the implant, because if you have to angulate too much, then what happens, there is an entire wall that is going to be affected by the access wall, and then the retention can be affected. So when you are making this decision of using the Kona system, you have to be very aware of how much the angulation of the implant will be, because then when you correct the angulation, you could be affecting the amount of surface that the retentive element will be attached to it.
Okay.
So what happened is I delivered this prosthesis. He called me next day. And as he called me, he says, "Doctor, why this is not staying?" So usually the first thing that I thought, well, maybe it's related with, at the time that I picked this up, maybe didn't have the right adaptation. I brought the patient back, and I decided to do this because when I carry with me different locator systems, which especially from Straumann systems, so different heights. And when I start working on that appointment, I realized that the friction of the unit against the two metal piece wouldn't be feasible for me to be effective. So I decided directly just to incorporate, due to number one, the previous experience with this patient, and I didn't want to waste more of my time and his time, because I want to get some sort of, you know, satisfaction coming from the patient and from us as well. So the way that I do this, as I have the same prosthesis, I eliminate the area where the conus was present. I use disclosing paste just to verify, PIP paste to verify the seating of the prosthesis. And then I pick up the housing of the locators, in this case on the maxilla, with extended range, that it was very retentive. Now I have the maxillary, now with an overdenture using locator. And I definitely found a position or a level of satisfaction that definitely I was very happy about this. And I thought that maybe we were getting to the point that, you know, this patient would be very happy with the
More
outcome.
comfortable with the app, yeah.
Yes. So what happened is after 6 to 8 months, he started facing this problem. A lot of plaque, irritation under the prosthesis. Dissatisfaction is still related with food getting trapped in certain areas. So at that point, we had, again, the conversation to say, would it be wise for us to move to the next step, which would be the logical step of having a maxillary implant support screw retained prosthesis, since we have the 4 implants that we already planned properly. And this is perhaps is an important message, is you have to keep in mind, and always I have been taught by my mentors, always you have to keep your end result, what you want to do in a patient's treatment. So, and the wisdom of working backwards. And I use this term all the time.
Begin with the end in mind.
Yeah,
as
so
the saying
basically,
goes.
because if I would have had a problem in here, not reducing enough bone, and you have a patient that is, the degree of dissatisfaction is quite significant, then you have to go through another step of the surgical intervention for you to create enough room that we need for a fixed type of prosthesis. Now, in this case, the lower arch also, now, obviously, the patient was satisfied, but what we start thinking is, wouldn't it be wise for us to help this patient so we can have an outcome that we can kind of put him in just a maintenance protocol, where we don't have to think more than just seeing him every 3 months for a clean. And we had this conversation, I recall, with you, where you were also part of the team, that we both agree have those even lower temporary implants converted into an implant support over the denture in the mandible, fixed type of position in the maxilla, create the appropriate financial structure that this patient can go through it, where we both obviously have to give up part of our, financial, responsibility as well.
And I think it's this at this point of his treatment, we really reflected back on the initial conversations we had with him about the pros and cons of overdentures, whether it be the tissue irritation, because an overdenture at the end of the day is a tissue and implant supported prosthesis, the irritation, certainly the food getting stuck, certainly the stability is not nearly as great as a fixed. So we came to a point that he expressed that he was not happy with this. It was not comfortable. It was getting food stuck, and he literally said, after paying all this money, that this is not great. And so we reflected on really the conversation that we talked about this at the beginning. And I think it's kind of, it's important to point out that patients, perhaps, especially if they have some cognitive challenges or understanding what was said to them, they may not remember what was said to them. This is what makes this a complex situation.
And even though if you come and you see the description of my writing in this case, I think that I have 120 entries.
Okay.
Or more, means that the documentation is very important.
Yeah.
That is it's given. But the point is, even though you present the information, you have discussed all these details regarding what the potential drawback of any prosthesis design, sometimes you can still have a patient with a pre-existing condition that can bring this challenge to you and to your organization. Because at the end, my staff is also sometimes irritated and frustrated because some of the reaction that he will have.
Yeah.
And then you have to make a decision, okay, how far you're going to go for the patient? And you draw the line to say, this is as much as I can do. The other question is, okay, when do you make a decision to come and say, okay, I'm not going to be able to help you. I think that you have to go and search for somebody else because you're going to have the chance to find somebody that will take care of you. And then you have to refund certain investment that this patient has put on you. But I'm the one that I'm trying to avoid that up to the maximum. There are occasions that I have done it, and I still feel that this particular patient benefits from what we have done for him.
So at this point, we decided that we're going to bite the bullet. We're going to deliver something that works better for him. And at this point, I think we both agreed that the time and the financial aspect of this case is not really a factor for us. We're going to do what we can do. to help them.
And one of the things
And that's a team approach.
Yeah, that's one of the
you
things
gotta
that-
talk to your team. You gotta make sure everybody's on board.
and that's one of the things that I really love working with you, because we both were the same, in the same boat regarding, look, this is the situation. And you had the predisposition to get into it and just help him out. I had the predisposition to do the same thing. And at the end, it was definitely a verification that the importance of a team approach on patient care is crucial.
And sometimes you can have this conversation with the laboratory, and they can be on board because
Absolutely.
that's the important part of the team. And certainly when it comes to redo of a case,
Absolutely.
I think the laboratory should be able to step up and say, I understand, they'll do what they can. So that's really a teamwork for this. So let's take a look and see what happens.
Yeah, so we have this image that is showing the lower denture to help us with implants to be placed in the lower arch. So we end up having 3 implants in the lower arch, removing the temporary implants that were on the anterior segment, and maintaining one of the posterior distal ones because it was working well. The distribution of the APS spread was such that we will have a predictable outcome in this case, especially since the anterior implants are solid in place, well distributed. Usually it's important still using the same prosthesis, eliminating all the housing from the temporary cylinders that I have from the temporary implants, and using a disclosing medium to make sure that we don't have any binding into the housing. When we are using locators, as you know, having the black housing would be an important part, the important part of the process of connecting this. Now we have the lower prosthesis that has been already captured, and we are using locators with, in this case, extended range. As you know, the extended range allows you to compensate for any type of slight discrepancy. And we have different retentive elements that we can select the amount of retention based on what you need. Now, one of the interesting part in here is that the retention, the mandibular arch now, it was such that the patient has difficulty removing it.
Mm-hmm.
On the maxilla, since we had the original cast, we use those to select multi-unit abutments so we can have the fabrication of a screw-retained maxillary implant support prosthesis. So this is a jig to verify the master cast that we have used before. The jig is then built at the abutment level. So we deliver the abutments. We have the jigs to confirm that we have an accurate representation in here of the master cast. Then we duplicate the existing maxillary denture that we know that we like aesthetically and phonetically and functionally. So we use that duplicated denture for jaw records and to transfer in all the data that is necessary for the laboratory to fabricate a fixed screw retained prosthesis. So we just use on the intaglio vinyl polysiloxane to stabilize the prosthesis, in this case, against the master cast. Phase one interocclusal record and mounting the cast. Interocclusal record we are taking in these photos. I'm not showing in this case because it was not very clean for the photo. So, and then we receive basically a prototype that's an important part. And this is obviously, at this stage, this patient is extremely satisfied with the final, fixed type of prosthesis that is now in his mouth. That is a prototype that is going to give us all the information for us to fabricate the definitive prosthesis. One of the things that is important in here to see is if you see the configuration of the anterior segment of the intaglio of the upper prosthesis, you have some degree of concavity. If the patient would have actually had the chance and the motivation to go through a surgical intervention, we could have actually modified the area with just a slight recontouring of the soft tissue and then adding acrylic just to give more convexity on the anterior segment. Since the prototype was working extremely well, I used the prototype so I can establish the occlusal scheme that is important in here. Now, when we have upper fixed type of prosthesis, and an lower overdenture, now you have a rigid upper element against a resilient lower element. So you want to have an occlusal scheme that it is as stable as possible. That's where we, at this point, work on the occlusion to the ideal, so we can have a bilateral balance occlusion, in this case, closed arch, bilateral balance occlusion. So you can add acrylic to the point that you can have, obviously, a prosthesis that is stable. And you can see also on the occlusal point of view that we have a stable posterior multiple contacts and the right occlusal scheme for this type of prosthesis.
Right.
Then we have the transferring of this into the laboratory. So we just captured the integrity of the prototype to have an screw retained zirconia made with titanium inserts, monolithic, except micro cutbacks on the anterior area. And this prosthesis was delivered. It was extremely satisfied. We torqued the abutments to 35 to where the implant, Stroman implants, which are those multi-unit abutments. The prosthetic screws were torqued to 15. That's important information, so we don't break screws, and that's always is important to be aware of it. This is the images of the X-ray after you have done the torque test of the lower definitive implants, which I believe that these lower implants are Megagene, aren't they?
These are correct.
Yeah.
Yes.
And this is the patient after we have completed all the treatment. And these are X-rays, photos taken after function for the period of time. And and he has remained in a 3 months recall. And that's kind of, I completely forgot about him. And that's a wonderful feeling in a good way,
Yeah.
you know, because we don't want to have patients obviously suffering for what we are doing for them, but even though we have the best intention to help them. But anyway, has been very stable over time. And I think that what is important in here is to share with the audience, obviously, some of the things that we all, through our experiences, built over time. And I think that there is only one diagnosis, which is important for you to, in everything that you are doing, it's important to confirm the diagnosis. But then you have so many multiple treatment plans. And sometimes you have to think, what are the potential challenges that you may going to be facing through the course of the treatment? So you have different options that you can apply and to help patients through. Then the interaction with other oral healthcare providers, I think that it's so crucial. I remain attached to this patient, even though it was a long journey. And then at the end, you feel the satisfaction because you were able to. And more than once, I put myself in his shoes.
Yeah.
Where, this is a PhD that 20 years ago or more has suffered a disease that has put him completely out of work.
Yeah.
And I spent a significant amount of time with him. And so those are the moments that you start feeling, how much you can do for patients to help them through. And the connection with the psychologist, psychiatrist has been crucial for me. So I built that amount of patience that I have to have so I can continue on and always coming back to you, and you were so kind to be part of it. Then the management of the patient expectations, I think, is a key element, especially when you are dealing with patients with cognitive issues and patients with mental illnesses. So just make sure that you clarify what are the things that you can do and you cannot do. Make sure that you document things properly. And this patient, believe it or not, even though you already saw what we have done for him, I had a phone call from the Maryland State Boards requesting records from me because the patient was complaining about it. I got a patient requesting to go for second opinion. So the point that I want to make is do the right thing, document things, make sure that you provide the right information before you get involved in procedures. And building trust with patients is crucial unless you do not want to treat them. Right. I think that the point is, it's so important to make sure that you have the trust coming from the patient. I recall this patient will finish always the email saying, by the way, I have the utmost respect for you and your clinical skills. and I think that you are great.
Which is something that
But-
we like to hear.
I
And
like to
that's,
hear. But then, on the other hand, 2 days later, I will be getting the complaint of, I cannot function with this.
yeah.
And then I think that the team approach, I think I cannot, stress this enough. It is so crucial in what we do, especially when you start getting with more complexity on the treatment of the patient.
Yeah, especially when it comes to the dialogue and the communication with the patient. I think we're looking at some very complex treatments, and when you have the added challenge of a patient who may have some cognitive issues and understanding, can you imagine what would happen if the players in the team, you as the prosthodontist, me as surgeon or laboratory, if we didn't have a concerted message, if we were conflicting each other? So I think that would definitely compromise the patient's trust in the team, but also it would confuse them and would create areas of potential issues. So I think that becomes even more crucial to make sure that not only we keep our dialogue with the patient complete, but also together. I always say to patients, they at the end of the day, they are the center of the attention. The restorative dentist or prosthodontist is the quarterback in this game, and the specialists are consultants supporting the ultimate vision. And those have to be completely clear, transparent, and continue to be aligned together. So it's again, doing the actual procedures. You're a master of what I do, and I've been doing the surgical part. Sometimes that's the easiest part. That's not the hard part. The hard part is how do we kind of maintain that patient on the happy side with continued support, knowing that there are so many different backgrounds and emotional and various things that can influence it. And that's probably the most challenging part of clinicians in general, not just dentists, but physicians, anybody who's involved in healthcare. I think that's where the biggest rewards are and the biggest challenges. It's also very rewarding to be able to kind of deliver something to patients and change their lives. And get that ultimate happy smile and the gratitude. I think it really gives a lot back to us after.
Absolutely. And one thing that is so important also to value our team members, because sometimes we think what we can do for patients, but if we wouldn't have all the support coming from our own team members, more than once this patient was quite a challenge for our staff members as well. And I think that there is no way that we can do what we are doing unless we have great staff that are surrounding us.
Absolutely. Completely team approach. Yeah. Well, we are out of time. Flavio, thank you for taking the time to present this patient, and your hard work, your dedication, your skills, but I think the most important of all, really your heart and your dedication to the patient is really remarkable. Thank you, everybody, for joining us. We look forward to seeing you again in our next complex case discussion series. Look for the recorded version of this program, which will be posted on our website. And thank you. Look forward to seeing you soon. Have a good day. Thank you so much.
Bye.